Hello, my name is Jennifer Rickerby, and I'm a doctoral nursing practice student at George Mason University. The objectives for this module are to interpret data and statistics regarding minorities with diabetes. We're going to compare cultural considerations for different cultures and the impact they may have on adolescents with diabetes. We're going to discuss the use of herbal remedies for diabetes in certain cultures and the implications of this practice. We're going to summarize the benefits of school-based diabetes self-management education. We're going to formulate the role of the culturally competent school nurse in improving outcomes for adolescents with diabetes. We're going to look at implementing the use of cultural assessment tools into practice, and there are a variety of different tools that can be used. We're going to assess diabetes patients for signs of diabetes, duress, and depression. This is the icon key. Once again, the head with the cogwheels is critical thinking. The movie screen is videos. The hammer is for actions to be completed, and the eye is for further information. So the case study, Sarah is an Asian female who visits the school nurse's clinic with complaints of extreme fatigue and terrible headaches. When she arrives at the clinic, she asks for a bottle of water. She immediately drinks the entire bottle and then asks for a refill. Sarah's teacher reports that she is leaving the class frequently to go to the bathroom, and she has had weight loss over the Christmas holidays. The nurse suspects that Sarah could have diabetes. Sarah reports to the nurse that her mother speaks very little English, and the only person they may see is a healer when they are ill. How will you proceed with this patient? Well, it is estimated that greater than 193,000 children less than 20 years of age have diabetes in the United States. It's the third most common chronic disease in childhood, and the incidence of this is increasing worldwide. In 2012, when we look at how many new cases came on board, type 1s had 17,900 new cases, and type 2 had 5,300 new cases. So children less than 20 years of age with the highest rate of diabetes is the non-Hispanic whites. This is for type 1 diabetes. So minority youth with diabetes, they experience poverty. So up to 70% of all children with diabetes live in poverty, and the type 2s live in more poverty than the type 1s. However, 70% is a very high percentage. Less appropriate treatment regimens are happening for minority youth than white children with diabetes. Minority youth have higher hemoglobin A1Cs. They have elevated cardiovascular risks. They have early signs of kidney disease, retinopathy, neuropathy, increased arterial stiffness, which leads to hypertension, and overall a decreased quality of life. So what is the Search for Diabetes in Youth study? The funding came from the CDC, and the NIDDK funded this large study. The purpose was to identify major knowledge gaps in understanding of childhood diabetes in search of solutions. And so the assessment of prevalence of diabetes type 1 in 2001 and then again in 2009, and the prevalence is increasing, and the trends of diabetes by age, race, ethnicity, sex, and diabetes types have all been tracked. Non-Hispanic whites have the highest incident. Behind them are non-Hispanic blacks and Hispanic. But when you look at the type 2 rates, what you're seeing is the non-Hispanic blacks and the American Indians are having very, very high prevalence from ages 10 to 19 years. So disparities for minority children with diabetes continues. That youth with diabetes from low-resource, racial, ethnic, minority populations are not receiving the recommended guidelines. So racial and ethnic disparities found that 26.3% of non-Hispanic white children report using an insulin pump therapy, compared to only 12.3% of Hispanic children and 5.3% of non-Hispanic black children. Children with minorities that have diabetes are not receiving equitable treatment. They are also showing markers of micro and macrovascular complications. They're evident at much higher rates in comparative to non-minority populations. So cross-cultural barriers that exist for minority youth with diabetes include lack of knowledge, fear and distrust, stereotyping, assumed similarity to other people, nonverbal communication, authorities in providers, physical contact or touch, verbal language, and style. So cultural competency is a learnable skill that allows the nurse to meet the social, cultural, and linguistic needs of a patient. And so this needs to be kept in mind that if our minority youths with diabetes are facing all of these cultural barriers, the one thing that will break through those cultural barriers is being culturally competent, and it is a skill that is learnable. So being culturally competent leads to the following. You can build better rapport, leads to a patient-centered approach since social and linguistic barriers can be broken down. It increases health information delivery, which increases health literacy and improves decision-making. It improves patient-nurse ratios, and as the nurse gets to know individual and families better, it also helps those relationship building. Better access to resources that are appropriate to the needs of the patient. As the school nurse becomes more culturally competent, they're able to identify what the patient's needs better and are able to line up better resources. So here we are with our case study again, and Sarah comes back to the office, and it's time to assess her cultural needs in order to decide how to proceed with calling her mother in particular, because you've decided that the student most possibly has diabetes, and you want to make sure you call this mother to get her to hopefully take this child to be seen. You don't want to terrify the mother as well as you don't want to under-inform the mother. You want to adequately inform the mother. So what procedure should you follow to call Sarah's mother? Ask Sarah to tell her mother what you think. Call Sarah's mother and speak to her about your concerns should she know some English. So speaking to the mother directly yourself, should you do that? Should you have the secretary call her who speaks some Chinese? Or D, contact the interpreter line to communicate with Sarah's mother to be certain she truly understands what your concerns are about Sarah. But you really want to take that extra time to get an interpreter on the line to make sure that the correct message is being portrayed to Sarah's mother. And most importantly, that she teaches that back to you and tells you what she heard you say. So an explanatory model of illness is something that can help healthcare providers to understand how the patient perceives the illness. So this helps us to ask patients what they think has caused their condition, what they call the condition, or what they think has caused it. When did it start? Why do you think it started? Sometimes patients think that there's a different cause to that illness, and there may be no cause at all. It may be a genetic factor, and that's something to clear up. What do you think the illness does, or how does it work? What will it do for you? What kind of treatment do you think you should receive? So this can kind of eliminate those issues with family members telling them they should have various treatments and what treatment they should actually have, to make sure to keep that clear and to eliminate any misconception. And what are the biggest problems the illness has caused for you so far? This model is can be worded in such a way that you can ask these questions to adolescents. So if you want to assess a person's cultural thoughts, feelings about illness, you can look at not only the explanatory method, social risk, fears, and therapeutic contracting. Okay, this is the RESPECT model of cross-cultural communication. So this is a method that you can follow to help you build rapport, show empathy, support, form partnerships, look for explanations, use your cultural competence, and develop ultimately trust. And that trust, although it takes time to build, is something vital, particularly when you're dealing with students with chronic conditions and their families. So this is now going to be individual cultural differences. So what I mean by individual is according to different cultures. I'm talking about their beliefs. So in Middle Eastern culture, it's the second largest population of diabetes in the world, not necessarily in our country, but in the world. And it's going to double in the next 20 years. They speak the Arabic language. Their primary religion is Muslim, although they do have other cultures and religions mixed in. Food is an important part of Middle Eastern identity and society. They have large gatherings with shared meals that consist mainly of rice and meats. The diet has shifted from consuming like whole breads and fish, dates, milk, to now consuming more rich and saturated fats and refined carbohydrates, which is probably accommodating for that increase or doubling in diabetes. The social economic development has led to sedentary lifestyle, which is increasing the risk for obesity and type 2 diabetes. Foot care is an issue as many people walk barefoot in their homes. Nurses should speak to proper foot care. Hindu beliefs are slightly different. Hindus will try home remedies prior to seeing a doctor. Often they seek help when they're very sick, so they often go for help when it's quite late in the illness. Religious celebrations include sweets and large meals, and it is very rude to refuse these, particularly during celebrations. Will consume bitter things to offset the sweetness of diabetes. Females will ignore their health and eat last in the home. It is unhealthy to eat often or have small meals, so their suggestion is to have large meals infrequently. During rituals, spiritual healers will use herbs to relieve illness instead of modern medicines. Diabetes may be due to laziness, excessive sleep, excessive intake of yogurt, meat, and soup of domestic animals, aquatic and marshy land animals, and grains and sweets. Stress, genetic, or hereditary factors are not considerations. They do not believe that this is part of diabetes. Smoking and alcohol, they believe, do not affect diabetes. Fasting is commonplace in Hindu and Muslim communities. Diabetes is a divine intervention or punishment. And acupuncture, massage, yoga, and prayer, hot tub therapy are better than medicine for diabetes. When we look at Korean culture, yin and yang are the balance in the body, and when there is an imbalance, such as diabetes type 1, it's just a matter of realigning yin and yang that will cure that disease in their belief. So herbs will restore the yin and yang, and so they are better than modern medicine. They believe that insulin cures all blood sugar issues, including hypoglycemia. Insulin is the final stage of diabetes. They believe in eating until feeling full. Health insurance is confusing to immigrants, therefore they do not buy it, or when they get ill, they often don't have enough health insurance. So Hispanic culture, 15% of the U.S. population. It's the fastest growing minority. It's the third leading cause of death in Hispanic women is diabetes. They're diagnosed at younger ages with higher blood sugars, with decreased insulin sensitivities, and they have increased severe forms of diabetes. They have higher rates of complications such as retinopathy, neuropathy, and lower leg amputations than whites. So why is there a higher risk for Hispanic culture? And this could be from language barriers, inadequate access to care, lack of insurance, low socioeconomic status, quality care factors, self-care behaviors, and general biological differences. So some common Hispanic beliefs may be that prayer will cure diabetes or relieve symptoms of it. Home remedies instead of medicine is commonplace. They have fear of injections. They have a fatalistic view of diabetes. Family may be unsupportive and influence patient not to use insulin. Cost of medicine is viewed as a burden to the family. Diabetes is viewed as a punishment from God, and insulin is seen as a failure to the person to control their condition, which is something that's been through a lot of the cultures that it's seen that when a person gets to the point that they need insulin with diabetes, they think that's the most severe form of diabetes, therefore they've really failed in terms of taking care of themselves, which we know that's not at all the cause of type 1 diabetes. So this case study, let's look at it a little bit further. Sarah returns to the nurse's clinic a week later after a short hospital admission. She was started on regular insulin in the hospital. Sarah tells you that her mother took her to the healer yesterday, and they started her on herbal supplement ginseng. The healer told Sarah she could stop the insulin injections, which Sarah was happy about because she does not like the needles. How would you approach this change in the regimen? So let's learn a little bit about herbs that treat hyperglycemia. So some cultures lack the faith in modern medicine. More than 2,600 plant species are used medicinally. But oily foods or bitter vegetables are used to restore health. Plant medicine is common. However, the problem is some of these herbs can actually cause hepatotoxicity or nephrotoxicity along with other complications. So here's our example, ginseng, for instance, and that's a picture of ginseng and how it develops over a 5-year period. The benefits that are believed for ginseng are that it aids in preventing and managing diabetes, according to Hippocrates, which is one of the drug references that is used. It improves hair and skin health. It helps in weight loss, It reduces stress and anxiety. Some of the side effects, there's allergic reactions, asthma attacks, insomnia, cardiac arrhythmias, hypertension, and hypoglycemia. So for a patient with diabetes, cardiac arrhythmia is very dangerous. Hypertension, which they may already have arterial stiffness, even young children, and hypoglycemia, if you're coupling this with insulin, you could definitely have a hypoglycemic event. So it's something to be aware of, the effects of such things as ginseng. And that's only just one example of an herb that may be used to treat diabetes. So it's important to approach the discussion about herbal remedies, but in a non-judgmental way, as I said before. So fasting and culture, Jewish, Christian, and Muslim cultures all participate in different holidays and celebrations that happen throughout the year. So here are some strategies during fasting periods that you can use when you're talking to students or talking to families about it, is to remind people with diabetes that they are exempt from fasting, but if they choose to, then you have to have an option for them. So if they choose to fast, then we have to monitor them more often, asking them to check their blood sugar more frequently. Consult with a healthcare provider for altered medication schedule to fit the meal schedule. So they really should avoid skipping the pre-dawn meal and the post-sunset meal, and also avoid intensive exercise during this time period when their eating schedule is altered, and monitor for hunger, shakiness, nervousness, lightheadedness, sleepiness, confusion, difficulty speaking, anxiety, weakness. These are all significant for signs of hypoglycemia. So why do we want to have school-based diabetes self-management education? Why is it important to do this in school setting? And this is because 17% of adolescents with diabetes type 1, they have a hemoglobin A1C that's greater than 9.5, which is very high. So they often have suboptimal glycemic control, and this leads to decreased academic performance, problems with peer relationships, decreased productivity, diabetes distress versus diabetes depression, which is a real issue. Ultimately, they have a reduction in their quality of life. They have a decreased life expectancy. And they also have increased healthcare costs that are increased by 6 times what a person without diabetes faces. So the formation of school-based peer groups enhances learning and relationship building. So according to the Association for Diabetes Educators, there are 7 self-care behaviors that should always be taught to adolescents with diabetes and all diabetes patients, and it's about healthy eating, being active, monitoring, medication, problem solving, healthy coping, and reducing risk. And I think the problem solving is a big piece, especially for adolescents, that needs work. And if you consider culture at the center and integrate it throughout all of these self-care behavioral educational pieces, then you're definitely going to hit the mark so much better with minority groups by thinking about cultural consideration. So adolescents with diabetes in school, they face a lot of challenges still. There's laws in place. There are still issues with limited ability to monitor and treat blood glucose independently. The law states that they are supposed to have access to monitoring supplies, and they are supposed to be able to have full access to their medications, snacks, and denial of this access to their supplies is a huge barrier, as well as denial of school activities because of their condition, lack of support, or the stigma that may be attached to diabetes. They may be hiding their condition to avoid being treated differently by kids. Teachers and other people might be afraid of their condition. So this all leads to adolescents with diabetes type 1 experiencing absenteeism, depression, stress, poor academic performance, and poor quality of life. So mental health is a big issue with adolescents with diabetes, and school nurses are right on the forefront. They're able to assess this and keep an eye on their patients. So we're going forward a little bit more with our case study. Sarah comes to you 3 months after her diagnosis during her daily blood sugar check and appears withdrawn. Her blood sugars are higher than normal and she seems very down. When you begin to assess her mental status, you suspect she might be developing diabetes distress. What can you do to determine if Sarah is experiencing depression? Individuals from different cultures may exhibit depressive symptoms differently. A PHQ-9 is a quantitative method to assess depression and risk for self-harm. So a PHQ-9 involves the two main questions, which are you feeling down, depressed, or hopeless, or have you lost interest in pleasure in things that you usually enjoy doing? And do you have any feelings of hurting yourself or others? That's the PHQ-2. And then the Q9 has a few other questions, and there is an adapted method for adolescents. And I'll just click on this link very quickly, and it will take us to the modified version of the PHQ-9. And school nurses should definitely have this handy because it goes through all the questions that are pertinent for students that may be experiencing depression. And this is a huge mental health issue that can occur. So diabetes, depression, they have a 2 to 3 times increased risk of not only depression with diabetes, but it's a more severe form of depression that they can develop. So 30 to 50% of our adolescents with diabetes experience diabetes distress or duress. It doesn't matter what you call it, but they feel frustration, hopelessness, fear, and guilt. And it's just from the overwhelming impact of the daily burden of having to check their blood sugars and taking their medications and people asking them what they're eating and what they're doing every single day. They don't have that independence and they don't have a good positive outlook. So these diabetes duress, especially when it's reaching heightened stages, or maybe they have other stressors that are attacking them at that particular time, can definitely lead to depression. And so the PHQ-9 is your go-to tool if you're concerned, and a bridge needs to be made for these patients to the community.